The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. I'm Julie Holuska, Vice President of Business Development from Centauri Health Solutions and your CAHAM Webinar Education Chair. Welcome to Hospital Talk, the impact on patient access during a time of COVID. Larry Roberts, Vice President of Technology from Centauri Solutions, who has over 30 years successful patient access and Medicaid eligibility and enrollment experience, will be our moderator. And for housekeeping purposes, you can use the chat feature for the questions we will add, and we'll address them during and at the end of our discussion. But it's my pleasure to introduce Gerilynn Sevenikar, Rewa Cooper, Kathy Jankowski, and Lisa Hagree. But let me give you a brief introduction of our speakers. Gerilynn Sevenikar is the Vice President of Revenue Cycle at Sharp Healthcare, and Gerilynn has 41 years of experience in healthcare revenue cycle and financial management. Ms. Sevenikar is responsible and provides executive oversight for hospital access service and business office functions, centralized billing and collections for all payer functions and classifications, charge master, health information management, and enterprise customer service and patient collections. She is the former chair for the California Hospital Association Payer Relations Committee, serves on several healthcare advisory boards, is an HFMA member, and is a Six Sigma certified green belt. Ms. Sevenikar was recognized in Healthcare Leaders Annual Report of 20 individuals who are changing healthcare for the better in 2012, and Becker's 2017 and 2020 Leaders to Watch. Ms. Sevenikar was a model developer for the Sharp experience, Sharp Healthcare's journey to become a high reliability organization, and she's a frequent speaker on the revenue cycle operations and integrity workforce management and innovation in healthcare.
Good grief, Julie. You could have cut it shorter. Like, how much time do we have left?
That was good. I loved it.
I'm intimidated.
Fabulous.
So impressive.
Next, we have Ms. Rewa Cooper of PIH, and Rewa has been in the patient access hospital industry for 25 years. She spent 15 years at Western Medical Center in Santa Ana, and at 2014, she moved over to PIH Health Downey as patient access manager. In her current role as IDS Administrator of Director of Patient Access, she oversees front-end revenue cycle functions of 40 clinics and hospitals, and currently oversees a staff of 275 employees. Rewa also is a member of CAHAM. Kathy Jankowski is the Executive Director of Finance for Methodist Hospital, Southern California. Kathy has over 34 years experience in operations and revenue cycle and on the payer sides. Besides her 8 years at Methodist Hospital of Southern California, she spent 8 years with Glendale Memorial. Kathy is a member of AHAM and HFMA. Mrs. Jankowski's key focus is on the process improvement and improving the patient experience. And not least, we have Lisa Hagree, is Assistant Director of Revenue Cycle Access Services at Sharp Healthcare. Lisa's been in the healthcare space for 36 years. She's held patient access positions at highly successful organizations in her career at Dignity Health, John Muir, Confluence, and Sharp Healthcare. And now it's my pleasure to turn the hospital talk over to Larry Roberts. And let's get started, Larry.
Great. Thank you so much. You did great, Julie. I loved it. And wow, this is quite an impressive panel of folks. So especially after I heard Gerilynn's title, I was like, wow. I mean, it's like, I'm slightly intimidated.
She set a high bar.
Yeah, definitely set a high bar. This is a great group. We are very excited to have all of you together. Today we're going to be talking about our COVID experience. I would love to say that that is over, but no, it's not. We are still living it every day. I think in the world of patient access, we are all together in it, and we're doing our best that we can with it. So to get started, I'm going to ask a couple of questions. I just would like everybody to share their experiences. I think that most of the folks that will be on the call today are really going to be interested in knowing kind of what happened to you folks. You know, all of a sudden out of nowhere, we had this event going on in China. It was very, very far away. And it seemed like, what is this? And then planes started getting canceled. And then we were swept up in a national health emergency. And then out of nowhere, we were in quarantine. That was a very traumatic event for almost all of us. None of us had ever experienced anything like it. So starting with that as the setting for where we began on this journey, I would like to pose this question. Rewa, let's just start with you. I told you I was going to ask you first. When you first understood what was happening, did you feel like you had like the right tool set, the right policies and procedures to really help you? Or were you kind of flying by the seat of your pants, or was it kind of a combination of both?
I think it was a combination of both.
Okay.
It was the unknown. So because of it being the unknown, it was a struggle for the staff, for our leadership team, our executive leadership. Everyone just had to all of a sudden figure out what do we do next? What are our next steps? We saw our census dropping, we saw our volumes dropping in outpatient. So I think that the first thing was just you're in limbo, and then you're trying to make a determination as to what are your next steps. You know, what do you do next with your team? So yeah, I would say that it was a struggle. It was a struggle for everyone to figure out what were the next steps and where do we go from here.
What was the first thing that hit you that you needed to do? Suddenly we were in quarantine, staff needed to be moved around, we had social distancing as the challenge. Kind of walk us through just a little bit about how that played out in your environment.
We needed to keep our staff safe. And as you know, we have, and I'm sure everyone on the panel understands, we have staff that are here and that have to be here to take care of our patients. And then we have other staff like our financial counselors and people that are doing pre-registration that really don't have to be on site. So one of the first things we did for the staff that were on site is rush to ensure that everyone was fit tested. So we implemented PPE, and we had to make sure that all of our front office registration staff that had to be here were fit tested. We implemented, simple masks. In the emergency department, we implemented the N95 mask, and we initially full PPE for staff to ensure that they were safe. The financial counselors, we started making a determination who really had to be on site and who didn't have to be on site. So those who didn't have to be on site, we set them up at home. We started working with our IT department to make sure that our financial counselors could get set up at home and get their work their work list or work their reports to make sure that they could do their jobs from home and that they felt safe and secure, and that also the staff that were on site felt safe and secure, in addition to our leaders. So at one point we even had where our leaders were now working from home certain days a week. And then those leaders that were on site were responsible for the whole house and had to round to make sure that all the staff saw us, that we were visible, and that they knew that the staff that were on site were supported and that we were here with them and not just working from home and not thinking about the fact that they had to be here. So I think that's a few things that right off the top that we put into place.
I love that. I think the visibility on site at the facility from the leadership, I think that probably made a huge difference for how your folks were reacting. I think everybody was afraid at that point. We're not really knowing what's going on, and we don't know if our family members are gonna be affected. We don't know if our coworkers are gonna be affected. We know patients are coming through the doors, but I think that visibility probably was very, very encouraging for the people at your facilities to be able to see their leadership being there. Kathy, how about you folks? What was kind of the same thing? What was kind of happening with you guys when it first kind of came down, and what was your initial reaction, and how were you dealing with some of what was happening? Was it similar to Rewa's experience?
Yes and no. You have to understand, we're a small standalone facility. We're not part of a region, don't have the advantage of having sister hospitals, and we're not maybe as large as what Rewa as organization is. And we have, you go through every disaster training, correct?
Yes.
And all these processes and policies in place for a disaster. The biggest problem was our administrative team would not acknowledge that it was a disaster.
Wow.
And so we put those steps into place. And so it was challenging. But what we did do is we worked with the nursing team in the ER. That was our biggest challenge, was in the ER. and keeping the staff safe. And so they already were doing the initial registration behind a window. So they were safe in that manner. But as far as doing the follow-up registration, we didn't have them going in the rooms anymore. We had the nurse gather the ID and insurance information, and then we did everything else on the phone, talking to the patient in the room. And so we were able to keep the staff out of the ER room and limit their exposure to the patient. And so that's what we did immediately in the beginning until the administrative team decided it was a disaster and started implementing. And I'm telling you, this is like from the very beginning, like in February and March.
Makes sense. Yes.
And it took a long time for the staff to put up the partitions in the main admitting, you know, the glass, not the glass, the glass partitions to keep them. And so we took our own steps and to make sure our staff was safe by limiting their exposure. So yeah, it was a really big challenge in the beginning. But once the administrative team acknowledged, okay, yes, this is a disaster, and then we started getting the support that we needed, and it was challenging in the beginning.
Yeah, it sounds like you had to be really resourceful. You had to work really closely with the nursing staff because they're the ones that were doing the interpreting what was really happening in terms of how dangerous is this? What kind of protocols do we need to follow? And how do I keep my people safe? I mean, that's the reality of that situation. And when there's a leadership vacuum or at least a temporary pause while they're trying to figure out what do we do, you have to do something because you got real people facing a real crisis. And it was very shortly after that schools were closing, the quarantine was beginning, staff was having to be moved around. So, you know, that's great that you guys were able to kind of take it and run with it from the beginning. So Lisa, kind of the same thing. I mean, how was that? I like the fact that there's a little different experiences here. And I see Gerilynn shaking her head because I'm sure there's going to be a really interesting combination. They're both from the same system. So it's going to be kind of fun to kind of hear a little bit about what you guys went through from the two perspectives.
So we actually got started thinking about this back in February when the first plane was coming, and we were having to look at our bed files and possibly patients coming into the system. And then when it hit on March 14th, 13th, the ED managers and myself quickly came together and we started talking, and we met every single day. We did and do continue to have the support of our administrative leaders at each of our campuses. We wanted to, just like the other panelists, we made sure the ED staff had the PPE equipment. We went to phone registration, follow-up processes. We moved away from the bedside registration, but then we quickly found that we were missing information. And so we had to implement quality audits on those ED registrations to ensure that information was captured. And that was by phone calls or working with the clinical care teams. We also, you know, we've been fortunate here at Sharp because we've been standardizing our ED registration processes across all 4 entities. And so we were able to look at our staffing models and our staffing plans. And as our outpatient volumes were dropping, the inpatient main admitting staff were willing to step up and help support. So we implemented a PAS surge plan. So for those cases where quarantining, schools are closing, staff might need to stay home with their family, themselves, their children, who could then step in and help support the patients that were still presenting to our emergency department. The other thing that happened in emergency departments is that quickly the clinical care teams developed a 2-entry process. Going through, every single patient was assessed, and they were either sent to our triage tents, the COVID evaluation area, and we had a registrar stationed there, or into the main ED and followed a different pathway. So that's helped also to make sure patients and staff are protected. It's been amazing, and I mean, flexibility, adaptability, think outside the box, and everybody jumped in and has done a fabulous job.
That's great. That's great. Gerilynn, what was that from your perspective? Now you're the leadership team. This thing kind of rolled at you. Everybody's looking to you to say, what do we need to do and how do we need to do it? How did that, you know, you're human too, so this was coming at you, and trying to figure it out is not so easy. How did that play out in your world?
Well, first, I'm going to commend Lisa and her team because they were absolutely amazing, resilient, very thoughtful and forward thinking in everything they did. It's interesting because I think back, and Lisa and I were here. I don't know if I was here. I think she was here where we were talking. The very first night we got our very first patient, because we were all kind of anticipating at UCSD in San Diego, we knew had a unit of 5 isolation beds, and they were going to take like the first 5 COVID patients. But that would probably be enough. The community would probably be just fine with the 5 isolation beds. And next thing we knew, they had 1 patient overflow. And we were like, okay, we can take that 1 patient. And just the way things moved, at least in San Diego County, we had our high in San Diego of 509 COVID patients in-house, in hospitals in San Diego County in July. And now we're running just under 200. So it went from 1 to 500 faster than you could blink an eye. And I had a conversation with some of my colleagues because we aren't used to disasters. I mean, we had wildfires, but you know, we knew where those were and we knew what was happening. But this is like really first major disaster planning in San Diego. So one of the things that we did that I think right out of the gate, and it's pretty much standard at Sharp Healthcare, we sat down, we looked at how fast things were moving, and we had a plan about what to anticipate. You know, if things move like this, should we expect to see in self-pay, and what can we do in our payer population? One of the first things we did was realize we were probably going to need to track these patients. And when the COVID testing was slow to come, and it was really, payers were given the waiver that they were supposed to cover. Initially, it was all COVID treatment, and then it was, you know, whittled down to maybe the COVID vaccine, and then it kind of transitioned to maybe if they're only positive COVID, but you know, if they're negative COVID, that you know, they won't be responsible for waiving any patient out of pocket. So watching that moving ball through this whole process has been a challenge for, I think, most leaders in every organization, and it just is testimony to what we know we do every day, but people take for granted. That now that awareness of, you know, they're on it. They set up we set up a plan. So we knew by design of a plan code who came into our facilities, and we knew who was COVID related. We knew who had a COVID test. So we anticipated what ultimately ended up being CARES Act funding and our need to actually extract that information and provide it, and HRSA funding and being able to track who came into our facilities with COVID diagnoses. So I'm very proud of this group in that they didn't just react, they anticipated what potentially those needs would be.
Yeah, the data capture seems like that, you know, that came fast at the IT department. And IT departments in hospital systems are notoriously slow to implement things, and so that, and oftentimes people are pushing and shoving, but they kind of came through. They came through because they were like in shock as well. And Gerilynn, you're right. I know that when you practice disaster stuff, I think we're all doing it in Southern California, earthquakes, you're doing the earthquake routine. I am from Hawaii. When I worked at Kapi'olani Children's Medical Center, we practiced for airplane crash in Hawaii because they would all be brought to the hospital and what would happen if there was lots of survivals. So your drills are really around the things that are most likely to occur. A pandemic. I told my business partner, I said, a pandemic to me sounds like, you know, the zombie apocalypse. And so how do you prepare for that? But that's not really what it was, but in your head, you had a kind of a different idea from what it really turned out to be. So
we had a different experience. We didn't have the surge. They kept talking about it and talking about it. And so there were two schools of thought. There was one side that wanted to be prepared and set up processes. And then the other side was, it's not going to happen. Let's wait and see. And so fortunately, it was the finance side that was, let's do something now. So we're going to do it. You know, the IT, the business office setting up codes, you know, we went ahead and we got prepared, but we weren't allowed to implement it until we got the go ahead from the administration. But, you know, yeah, it was frustrating because we never really had a big surge. I think our highest population was 70, which we not easily, but we had more than enough ventilators and ICU beds and whatnot. So we never did a big surge. And because of that, the administration was not as responsive as quickly.
But I bet you they have a better plan today than they started off with, because as a result of having the experience now and being faced with some things that became a reality very, very quickly for everyone. I think I want to kind of take us through, you know, this journey a little bit further down the line. So with Rewa, I would ask you, as you're starting to move through dealing with this process, now there's things happening with employees. Employees are saying to you, I have a sick family member. My kids are coming home. I'm having issues with these kinds of things. And you have employees who are afraid if they can maintain social distancing within the work environment or they can't, and they're just nervous. So kind of walk us through how you dealt with the human aspect of that for your patients' concerns, your employees' concerns, their concerns about what's going on in their personal life. Kind of walk us through what you did and any kind of innovative things that you think you folks kind of applied to that situation with working with all of these people.
So I will say that flexibility really was like a key word. With this, you have to be flexible with your staff. We had a number of leave of absences. So the staff that were here, we would work with them in regards to their schedules. Maybe there was staff that had children at home and they were doing homeschooling. So in the mornings, they had to focus on that. So especially if there's some work that could be done in the evening or maybe pre-registration, we would have them do the pre-registration in the evening and then allow the staff that didn't have that to do the morning work. So just really being flexible and working with your teams and really getting to know what their needs are. You didn't want to lose your staff based on this. So the staff that you had in place, just really working with them and being flexible, even up till now. Like we're still really working with our staff and having flexibility as it relates to schedules and trying to work through the issues. Working with temp agencies to bring people in when you have so many people going out on leave of absence that you really can't manage your department. As far as the patient experience, one of the things we have an outpatient wells department at one of our locations, at our Whittier location, our PIH Health Whittier location. And we do a large number of our outpatient registrations there. So the lobby there is not very big. And with COVID, you need to learn to adapt fairly quickly. So we put in place where we would have those patients come in and check in, and then we would have them wait in their car. And we would text the patient once it's time for their appointment so that patients aren't, there's not a large number of patients sitting in the lobby. It made the patient feel better that they had an option to go to their car and wait versus sitting in the department waiting for their test. And that just goes along with the screenings, you know, and making sure that they're checking temps and giving patients masks and just following the CDC guidelines as required.
I was noticing that hospitals also started funneling patients through an entrance into the main facility, maybe a single entrance to sort of help really control infection control and to give the patients a consistent experience so that they knew what to expect. So and
not just patients, but staff as well. So all locations, all staff were required to go through one entrance so they could be screened and go through all of the CDC required screening. And we did this at every clinic. We did this at all the hospitals. And I do feel that it did make the patient feel as if they were a little safer. ER, like some of the other ladies were stating, they went through the screening process at the tent, and then they were sent out according to what their symptoms were and what they were here for. So I do agree that fairly quickly, the hospitals jumped on board with CDC requirements and what was necessary and needed, and we just aligned with that.
Wow, that's great. That's great. I think one of the lessons that we're all learning, and as after everybody shares about this, I think one of the lessons we're learning is that flexibility, we may not have been as flexible in the past as we are today, as we considered some of the real human impact COVID had on not just all of us professionally, but our families, the public at large, our employees. And so maybe that becomes a takeaway moving forward. And if we ever get past COVID, that we can have that same kind of flexibility in the future, because it seems to be working really well for a lot of folks. Lisa, was that kind of a similar experience for you like Rewa had in terms of working with all of those various groups within your system?
Absolutely, and we continue to work through many things because many schools are still doing distance learning, and I think it's been a real stressful time for our employees because they do have family members that they're caring for, or they are worried about themselves. So that empathy level and really understanding and setting up modified work schedules where we can. I myself, as a leader with access, I have continued to work on site since the very beginning because my staff and my managers and everyone is expected to be there. So it's been very important for me to lead by example and be there. And that, I've had people actually thank me for coming and rounding and thanking them for showing up. But continuing to be flexible and really, SHARP has been amazing. We've implemented a lot of policies and procedures that protect employees who have challenges during this time so that they don't need to worry about their job specifically, and really working with them because we really highly value what they bring to the work environment. And then the partnership with the clinical care teams has been incredible as well. I think it's really brought us together. The thing we are missing out on, I think, is that human connection. I previously had monthly manager meetings with my team. I would always cook something for them because I like to cook. I'm a nurturer. And it's like, oh, now we meet via Teams, and I don't, I can't bring my favorite foods to share with them. And so, those things, I miss that connection and being able to be with them and see them in person.
This is sort of the next
best challenge.
Yeah, the next best thing is sort of our conferencing and seeing each other. It's reassuring to me personally to see you folks. I just like this. We're all doing the same thing. We're all sort of safer at home, but it's really nice to see others. So Gerilynn, how was that also from your perspective within your healthcare system?
It was really interesting because I knew that the hospital teams had to be present. And I knew that there was a contingency of the employees that reported into me that, they were here and we need to make sure that they knew we had their backs in a lot of ways. Just making sure that if there was a protocol implemented for the clinicians, that same protocol is considered for our employees. And lots of times, I'm not saying this to be, like unthoughtful of our employees, but they get missed often. Usually it's the clinician who's, hands-on patient that gets first consideration for things, not realizing that our employees are equally present with the patient, and sometimes potentially longer.
Yes.
So we did have a group of employees here in my central business office, and we have a very strong and talented employee health department, and I trusted them. I trusted what they told me we needed to do, and we made sure that our work area was safe. We had a group of employees that, because they had immunities that they needed to go home, they went home. But the majority of my office actually still presents to work every day. We have a very flexible work schedule. They can come in as early as, I think, 4 o'clock in the morning if they can still do their work at 4 o'clock in the morning, and they can stay as late as 11 o'clock at night if that's what works for them.
Yeah.
But we have a protocol where the area is probably about as sanitary as you can find. People are walking around, making sure everything's clean. We put up the barrier, so we have partitions where partitions never existed before, plexiglass just about everywhere, because we want to make sure the work area is safe. Now, there are employees that are working from home, but I'm going to be a firm believer that if you never see your employees, it does impact the culture of your organization. So somewhere at the end of the day, there's going to have to be a fine balance of what's the right amount of work from home and what's the right amount of collaboration and being with your teams. I can tell you from my personal perspective, I probably have the best relationship right now with the people that are showing up in the office. If there are employees that aren't showing up in the office, we don't talk as much. If something comes up in the workplace, they aren't here. And you miss a lot when you're not here. So, it's going to be funny to see how this all pans out from a culture perspective. And again, I do believe there's going to be a fine balance of what's that right blend of working from home and then being part of a collaborative team.
As we're part of a large company, we have about 1,700 employees, and we had to mobilize, we had to literally move 1,100 of them to work from home within 7 days. And so that was quite an effort. And then we were worried about the very same things you're talking about, Gerilynn, about the fact that, you kind of lose touch with your company's culture. And we're still in the process of migrating people back into offices, but then trying to maintain this balance, still maintaining flexibility. I think all of that is super, super important, that you still have that flexibility. You don't lose the human component, but that you still do keep people feeling like they're part of an organization and a team, and that we're all in this together. I think that's super important, is that message that we're all in this together. So Kathy, now your situation might have been a little different about what you guys were facing in terms of employees and patients and how you were managing those kinds of changes. You want to share with us a little bit about what you guys went through in terms of flexibility and helping with those? Oh, I think you might be on mute.
I had some background noise. I didn't want you guys to.
Okay.
Yeah, because we're a standalone facility, we were able to reach into other departments and partner with them to assist us. For example, the clinics were closed during this period. So we were able to cross-train their staff to work in the ER, help out there, because we had staff that, got sick or had to take a leave of absence. As Rewa was saying, trying to be flexible with the employees and their schedules, and having to deal with kids at home and whatnot. We were not able to give flexible work schedules because we have such a limited staff. So they were not able to work from home. And if they couldn't work their schedule, they could work half their, whatever hours they could work during their normal schedule, we allowed that. And then we also reached into the business office and cross-trained that staff. We asked for volunteers, and we had several chime in and offer to assist and learn a different and work in the ER. And, it was scary. I mean, a lot of people were afraid they were going to get COVID and they didn't want to do it. And so, but we did have some brave ones volunteer, and that assisted us tremendously because we were so short-staffed during that time. And so that's how we accommodated it during this period.
I think, a long time ago, I worked in patient registration in the emergency room at Kapilani Children's Medical Center in Hawaii. And one of the things that I thought was innovative at that time, and I'm not going to tell you when because that will date me, but what I thought was innovative at that time was the fact that we did cross-train back and forth between inpatient admitting and ER registration. and because we had a really high burnout in ER registration. And so it almost was like for them to move over to the inpatient admitting side, it was relaxing and there was less stress and there was less crazy stuff going on. Patients weren't throwing up on you. That was one big plus. And you didn't have to take an extra set of clothes to work in that kind of environment. So it's kind of interesting to see that cross-training, that COVID kind of encouraged that to happen because you had shortages within the organization. Now, I want to ask about this, and I want to ask about it because it was brought up to me by a friend of mine, who's Becky Peters. Many of you probably know her. She is with the Banner Healthcare System. And one of the things that they did, and we also did as a company, is that we changed the employees' salaries who were working in the emergency room environment. We did not present that as hazard pay. We did not do that, but we did the differential adjustment because of what was happening and the financial impact on their families and the community. And we wanted to make sure that we sort of stabilized that environment for people who were working with patients, who were faced with people who had COVID every day. And many of the registration staff is not used to suiting up in PPE to be able to participate in that process. Not every facility provided PPE for registration people, but some facilities did. So anybody want to comment on that?
So we did do COVID. I'm going to call it COVID pay, but we did have actually a pretty substantial increase per hour for the staff that worked in our front office for our urgent care. Because I do have oversight over a couple of our clinics. So for all of our urgent care registration staff, they were included in that. Our ER registration staff were also included in that. So we did provide the quote unquote COVID pay for registration staff. And it was really nice that the registration staff was included, because I'm going to mimic one of the other panelists that we do sometimes get lost in the mix. But in this case, we were included, and it did make the staff feel as if they were, they were important. They were noticed. That they were a part of this, and that they weren't excluded from it. So yes, we did do COVID pay as well.
Yes. Did anybody else kind of participate in that?
We're a union, and it was not contracted in the union. Hazard pay was not included in the contract. And so, no, we didn't.
We're not trying to say any of this is good or bad. We're not trying to point that out. What we're trying to do is to share with our audience and all your expertise, just to show the kind of different angles that everybody went at this, to see how they were going to handle keeping people. As a private company, we did give people working on site at a hospital differential as well, because we were very concerned about an exodus out of the facility and being able to deliver services. So that became important. Gerilynn, I know you're dying to say something. Jump right on in.
Well, there was a very short period of time that Lisa and I tried to sneak in an override incentive because we did have an issue with employees feeling like, schedule me anywhere, don't schedule me in the emergency room, because it's unreasonable for you to expect me to take on that risk. So we did it for a very short time. The clinicians weren't getting any hazard pay, so there was a discussion about our COVID pay, or whatever you want to call it. So it really is about equity across all employees. And at that point, since the clinicians weren't getting an override pay, we decided not to continue the override path on our side. It was definitely appreciated during that short period of time. Now, what we did do is we've just closed our fiscal year, and because we managed quite well, I'd have to say, in these very stressful times, we did actually give a incentive bonus to each and every employee in the organization for managing this time as well as they did, and still allowing us to be financially strong. So we kind of went maybe at the end of the game and gave that acknowledgement instead of doing an incentive concurrent during.
That's great.
And the other thing that we did, yeah, it wasn't a financial incentive, but it was more thanking staff and leader rounding and supervisor rounding and just checking in with the teams and, you know, maybe bringing in, you know, protected food in individual wrappers where, you know, they could be thanked. And so there were a lot of creative ways that the leaders and the EDs were able to appreciate and thank the staff. Even though it wasn't a financial bonus or incentive to their paycheck, there was a lot of gratitude and appreciation that the leaders were doing.
And I want to piggyback on that because of our small community. We had, in the beginning, almost every night we would have donations of food. They would buy dinner for the entire hospital.
Right.
And,
Wow.
and admitting loved being included in those. So every day you get a free meal. For a while there, it slowed down as time progressed, but you know, it was a great outpouring from the community.
I think we're.
Christian would also, you know, treat dinner, pizza and stuff like that sometimes.
Yeah, it's all the human, personal touch things that tell people that they're valued, and that becomes super important. Monetary is one thing, but a lot of that just recognition, just saying, I'm so thankful that you're here every day. And having leadership on site, showing up, checking in, saying, are you guys okay? We want to make sure, is everybody following the rules? Are you guys feeling safe in those environments? I think our audience will like to hear that, because that's important. If you're not doing it now, you may really want to consider going out there. We're looking at a second wave in some locations, and hospitals right now, depending on where you are starting to see that rise in numbers. And I think there's going to be some lessons learned. I think we only have time for maybe one more subject to kind of talk about. And I do want to talk about lessons learned. You know, moving forward, or are there any processes or procedures that were things that maybe have been born out of the COVID experience, but you think will outlive it? You think it's something that you're going to carry forward to the future. So Lisa, you want to kind of maybe share with us if there's something going on that you think you'd like to see in the future keep going at your facilities?
I am a huge fan of digital access services, touchless registration. So that absolutely is something. And the other thing I want to do a shout out to our patient financial services self-pay manager, Perla Pace. She quickly implemented DocuSign processing for our Medi-Cal self-pay patients to complete their applications online. I mean, it's just been phenomenal, and that process definitely should stay going forward. I think some of our payer, where they've accepted verbal authorizations, I would love to see that go forward. It really helped move us forward in the digital access services line, and I would love to see that continue.
That's great. Rewa, how about you? What happened? What takeaways do you have from this? Things that you might want to keep?
You know, I actually like the plexiglass. I like having, I feel like the staff feels safer with it, just having the plexiglass in the registration areas, and gives them a little distance from the patients, but not too much where the patient doesn't feel that personal touch. So I would say just keeping with some of the practices that we put in place. It's amazing how now we think about when we go into the store using the hand sanitizers, and when you come out using the hand sanitizer, and you know, things that we just probably didn't do as much of as we're doing now. I would say keeping some of those practices in place to just make the staff always feel safe, not just during a pandemic.
I think one of the interesting things that I think, Rewa, you had mentioned to me before, is that in the past, people come to work and they're sick, and they would cough and hack, and they're sitting in their spot, and they would like be suffering and sneezing and going, and now we're like, no, go home, not pass go. So isn't that sort of a procedure change now, where at one time we would let people work in that condition, and now we're saying, nope, no, you don't come in. Don't come in. If you're coughing and you don't feel well, you've got a fever, And I think you were telling me you're doing temperature, you're taking temperatures on employees and as they come in to make sure that they're okay to work.
Yeah, every employee is screened at the door. They take their temperature, they ask all of the CDC required questions, and they're hand sanitized and they're given a mask. So you're not allowed to wear outside masks. Once you walk in the door, you're given a new mask, your temperature is taken, all the CDC questions are asked, and they have to take your temperature. So we have actual paid screeners at every entrance of every PIH Health location to ensure that we're following the CDC guidelines. And if you answer yes to a question, then you're immediately sent home. You're to call employee health, and then they go through a screening process. They have you tested, and you get those results back within a few hours to determine if you can come back to work the next day.
Wow.
So we're taking this very seriously. We want to ensure that our patients and that our staff are safe and healthy when they come to work.
That's great. Kathy, do you have something similar going on? What kind of lessons learned do you have that you're walking away with from this experience?
The remote registration is very helpful. I mean, it was something that administration did not want to spend the cost to implement, but it was something they were forced to do with COVID, and it has significantly helped the staff, especially now that they're requiring all patients to have a COVID test before surgery or any before they can come in the door. So that has increased our main admittings time twofold. They have to register a patient twice now, one for the COVID test, again, and for the pre-admission and for the procedure itself. So this remote registration has been a plus. And yes, we will continue it going forward. And then also on everything that Rewa said, you know, all the other different changes we made, I think we should continue.
Yeah, we noticed a notable increase in productivity when people went to work from home. That was something that we were measuring because we were very concerned about the loss of productivity because there's lots of distractions at home for all of us. You know, I get the guy coming to the door, you know, ringing the doorbell, and, you know, that's a distraction. You have to stop and walk away. And we found out that productivity for some positions went up substantially, and it was kind of an interesting thing. So Gerilynn, same question for you. What did you walk away with and think that, yeah, we need to continue to do this because it's a no-brainer. It's going to help us in the future.
Well, transition to digital formats is like number one. Telehealth, of course, is like number two. Everything's going to move to a more telephonic or video environment for us. But I think the safety protocols, it'll be interesting to see what happens with flu this season. If, you know, we're all taking care of ourselves and maintaining those precautions, we actually should see a reduction in flu this year, which, you know, as a finance person, I do kind of depend on that a little bit, but it'll be interesting to see what happens this year as it relates to the spike in flu. You know, I just think everything is so different right now than it was. We're focusing on self-serve. We're focusing on trying to make information available to our patients any hour of the day that they potentially would want to get to it. Trying to make everything as seamless as possible for them. And all of these are things that we had always said we wanted to do, but it's amazing how the agility of this organization when something needed to be done. It was, you know, all the obstacles that used to exist, all of a sudden we just broke right through them, and things that would take months to get done suddenly could be done the next day. Now, what's going to happen with that long term, now that we know things can get done the next day? That'll be interesting to see too, because, you know.
I'm going to say IT might not be on board with that.
It'll be interesting to see, you know, the whole, you know, it needs to get them in process in line. And now that I know you can do it in a day, it's going to be a whole different story.
I need to reach out to Gretchen or Julie. Do we have anybody sending in anything on the chat function? I don't know if we said, if somebody wants to ask a question, we've got some great panelists here. We've got a few more minutes. I am quick to hog it up myself, but I just wanted to reach out to see if the group has anything that they'd like to ask that they didn't get from our amazing panelists. And so feel free on to use the chat feature to go ahead and submit a question to us. We can either throw it out to the entire group, or we can actually ask any one of them individually.
We don't have any chat questions yet, but this is, I mean, I'm enthralled just listening to everyone. I could listen to this all day long. It's so compelling and a lot of learning right now.
Well, we did have the one, unless we already asked it, which was, is there one event or action that is most memorable during the time of COVID?
Yeah, that's a good one.
So who wants to take that? What was the most memorable moment? I bet you it's going to be a human experience.
This is Lisa. I'll take that one. I was so impressed with the sharp leadership overall, the revenue cycle leadership, the patient access leadership, clinical care. We just all jumped in and basically rolled up our sleeves. And what do we need to do to make this happen? How can we continue to care for our patients? How can we continue to care for our staff? We need, listening to the staff and what was important to them and making those changes as quickly as we could. I'm so proud to be part of such a wonderful, caring organization.
That's great. That's wonderful.
Just jump into that too. I want to talk about our organization and the communication. The communication that we received from our leadership team, our executive leadership team, was amazing. We have an intranet page. Every day, every COVID, all the COVID information, all the numbers were uploaded to that every single day. Our CNOs started doing video call. They would do a video and send it out to all email users with all information. We had daily huddles with our leadership team, and anyone who wanted to get on the huddles would. My leadership team specifically would have huddles with their team twice a day. Just the communication through this has been amazing. And it started from our executive leader, Jim West, all the way down to my VP of Revenue Cycle, to our CFO, to just everyone cared so much that our staff received all of the information that they needed. Our website, everything, our Facebook page, we shared everything. We were truly transparent. And I'm very proud of that.
Let's give a thumbs up to the IT team who maintains that website and who did that data capture, because they did a great job. I'm the VP of technology, so I got to do that. Because, I poke fun of us, but at the same time, I know that, when push comes to shove, we hopefully are going to be there for you when you need us to really do something.
I think my most memorable moment was in the very beginning when the staff was really nervous about COVID, and the ER director volunteered and said, hey, this is something we can do to make your staff feel more comfortable. And because they were not provided the PPE that the nursing was. We didn't have enough. It's not that, they were trying, it was when we didn't know if the surge was coming or not, and they were trying to hoard, make sure we didn't overuse it. And so, so the nursing stepped up.
That's wonderful.
Which is unusual, because up until before COVID, the nursing was not as, would not coordinate as well with admitting.
Yeah, it's sort of
where we got their information kind of stuff. But now there's a lot more cooperation and teamwork between us and them.
Gerilynn, do you have?
Yeah, I think you hit on a good point, because literally we were counting masks and allocating masks out and rationing where we needed to, because we knew supplies were low. And it was I think that was probably the scariest times, when we knew that there were people out there potentially being compromised because of supply issues and PPE issues, and that doesn't feel good.
It's so scary for everybody involved. So I think I would like to maybe have us think just for a minute. I think we've got a few minutes here. Am I right, Julie?
And we do have 2 more questions.
Oh, we do have 2 more questions.
We do. How did your facilities handle those staff members that had symptoms, tested negative, but still claimed symptoms? What did that process look like?
Ooh, interesting. Anybody want to grab this one?
Yeah, they stayed home. They weren't allowed to work.
There you go.
And we let EOHD make that
Yeah.
decision for us. It wasn't, I stayed out of it, talked to EOHD, and whatever they decide is what we'll go with.
Very practical.
Okay, and then we had, how did you keep the morale high over the course of months when it's evident staff are clearly drained and weary? I need some new, fresh ideas.
I sent out thank you cards with a gift certificate to Starbucks individually with a note to the team member trying to point out something specific they did and that we thank them. We have a supervisor that loves to bake cupcakes and individually wrap them.
That's adorable. I love it.
That's a tough one for me because we're very strong on employee engagement, and really we did a lot of things to make sure that our employees are connected with us, that they know how much we appreciate them. We did have our revenue cycle week, so we did actually dedicate a week to just our employees. We theme it, and we have a special event every day in recognition of the employees. I sent a gift to their home with a letter to every single employee, so every employee in the division got a letter from me. We also have, I think we had a whole department, like if Lisa tells me, hey, we need to send something to this department, we send thank you notes to individual employees to their homes. And then we do the standard things. What's a miss for me is I used to have monthly meetings with the employees on the month of their anniversary. So we'd all sit down and have breakfast together, and we would just chat about what's going on in your areas. What kind of things do you think I need to know? What's going well? Where can we improve? Don't have those monthly meetings anymore. I used to have all hand meetings with all of my employees every month so that I could update them on everything. And those have all gone virtual. So we've gotten one in under our belt, and we're trying to get another one in. I think employees where I'm saying I don't feel connected to my employees, they also don't feel connected to us. And it's really forcing that connection would probably be the one thing they would appreciate the most. And then I have, some of you have heard, we have the gamified workflow. So I'm able to send notes to my employees during their work, while they're being productive, and kind of keep things moving with them and those areas too.
The webcam is not perfect for that, but at least you can do some one-on-one webcam stuff with folks, and so they can see you. It's not perfect. I don't think we have a really long-term solution to this disconnect. But like I said, for me, just as your moderator today, it's just comforting for me to see all of you and get to listen to your shared experience, which is incredibly invaluable, especially to the folks that joined our session today. One thing I want to leave the group with in just something to think about, I've been thinking about it recently, is that over time, over the next year, we're going to enter a period involving the vaccination of folks. And then we're going to be facing some complicated human things that happen when you have vaccinated and non-vaccinated people. And so I think that if your teams are not thinking about it now, definitely you need to add it to that discussion list for the future, because it's going to be interesting when we have protocols in place for people to wear masks before they enter, and the counter is, I've been vaccinated, here's my card, or here's whatever. And we're going to have to deal with that. That's going to be a real life experience for clinical staff, for registration staff, for security, and for all of the people that are actively working to keep everyone safe within the environment. So it's a discussion for another time, but it's definitely something to kind of put on the back burner to think about, because I think we're going to be facing that around the corner. So Julie,
well, thank you, Larry, for moderating. And I want to thank each one of our panelists. You were wonderful. It's a great job. We're going to want to do this every couple of months with CAHAM and do a panelist discussion. I think that this really gets people thinking and asking questions. And it's really great to see what our hospital friends are doing the different areas in the state of California. So thank you so much. We're going to put the webinar on our website so you can listen to it, and we'll also have it on LinkedIn, I think, too. So thank you so much. Have a beautiful weekend, and thanks so much.
Thanks,
Thank you,
Paul.
everybody.
Thank you.
Everybody.
Bye.
Everyone.
Bye.